Hi students, today the class is on neurotransmitters. Neurotransmitters are the substances, chemical substances. These are responsible for the transmission of the impulse at the synapse level. So these are the endogenous chemicals that allow neurons to communicate with each other throughout the body. They enable the brain to provide a variety of functions through the process of chemical synaptic transmission. So we have two types of synaptic transmission, electrical and chemical. In chemical synaptic transmission, there will be a role of neurotransmitters. So they will allow neurons to communicate each other throughout the body. So they are integral in shaping the everyday activity which are occurring in the life. Alterations in the various neurotransmitters, they observed in the various neurological disorders like Parkinson's disease, schizophrenia, depression and Alzheimer's disease. So criteria for a neurotransmitter. So a chemical substance to be called it as a neurotransmitter should fulfill the following criteria. What are they? The transmitter must be present in the presynaptic terminals at the synapse level. So they should be at the presynaptic nerve terminals. Next, enough quantity of transmitter must be released from the presynaptic nerve concomitantly with nerve activity to have an effect. So enough quantity of neurotransmitter should be released upon activation of the presynaptic neuron. Next, the effects of experimental application of the putative transmitter should mimic the effects of stimulating the presynaptic pathway. So if you apply experimentally also, the same transmitter should be giving the same result. If available, specific pharmacological agonists and antagonists should stimulate and block the neurotransmitter respectively. So if you are giving agonist, it will stimulate, or if you are giving antagonist to that particular neurotransmitter, it should block the response. Next, there should be a mechanism present that terminates the actions of the neurotransmitter. So what is that mechanism? It may be reuptake or enzymatic degradation. That mechanism should be present at the synaptic level to terminate the actions of the particular transmitter. So these are the criteria for calling a substance as neurotransmitter. Okay. Next, coming to the classification of neurotransmitters. So we have biochemical classification and physiological classification. So in biochemical classification, the neurotransmitters are divided into two groups broadly. So what are they? First is the small molecule neurotransmitters. They are acting rapidly and they will show acute response. Second one is the neuropeptide transmitters. They will act slowly and they will have a prolonged effect. So in small molecule neurotransmitters, again we have four classes. Class 1 is the acetylcholine. Okay, class 1 is the acetylcholine. Mainly acetylcholine will be seen at the neuromuscular junction, and all preganglionic autonomic neurons we can see the acetylcholine, and all postganglionic parasympathetic neurons. Acetylcholine is a neurotransmitter, and postganglionic sympathetic neurons which are giving supply to the sweat glands and the skeletal muscle blood vessels. So this is the exception that you must remember. So what are they? Postganglionic sympathetic neurons to sweat glands and blood vessels of the skeletal muscle. They are releasing acetylcholine, and some amacrine cells of the retina and many parts of the central nervous system will release acetylcholine. So where the acetylcholine is present? At the NMJ, that is neuromuscular junction, that is junction between the alpha motor neuron and skeletal muscle fiber, and all preganglionic autonomic neurons. So they may be sympathetic or parasympathetic neurons. Preganglionic neurons, autonomic neurons will release acetylcholine. Then all postganglionic parasympathetic neurons. So Parasympathetic postganglionic neurons will release acetylcholine, whereas sympathetic postganglionic neurons at some places, what are some places? That sweat glands and at the blood vessels of the skeletal muscles. So these will release acetylcholine, and amacrine cells of the retina and many parts of the central nervous system will have acetylcholine as a neurotransmitter. Next, coming to the amines, biogenic amines. They are catecholamines which include epinephrine, norepinephrine and dopamine. Then serotonin and histamine. Next, class 3. It includes amino acid as a neurotransmitter like GABA, glycine, glutamate and aspartate. Next, class 4 includes nitrous oxide. Then small neuropeptide transmitters. The second classification, neuropeptide transmitters. They are including neuroactive peptide, pituitary peptide, peptides acting on the gut and brain, and neuropeptides from other tissues. So they are acting slowly. They will have a prolonged effect. Now coming to the physiological classification of the neurotransmitters. So they are classified into excitatory neurotransmitters, inhibitory and both. Excitatory neurotransmitters consisting of glutamate, aspartate and nitric oxide. Inhibitory, they include glycine, GABA and serotonin. Both inhibitory and excitatory effects are shown by acetylcholine, norepinephrine and dopamine. So this is the physiological classification. We are discussing about the biochemical classification like small molecule and neuropeptide transmitters. So first it includes acetylcholine. Okay. So first coming to acetylcholine, you see the synthesis of the acetylcholine. So acetylcholine, as we discussed, it is the principal neurotransmitter by many neurons in the central nervous system and at the NMJ, and all preganglionic neurons and all postganglionic parasympathetic neurons and postganglionic sympathetic neurons which are supplying sweat glands and blood vessels of the skeletal muscle and amacrine cells of the retina. All these will release acetylcholine as a neurotransmitter. Now, these neurons are called cholinergic neurons. So, neurons which are releasing acetylcholine, they are called cholinergic neurons. Next, so see this the synthesis and storage. So, acetylcholine is synthesized within the presynaptic terminal. This is the presynaptic nerve terminal. This is the postsynaptic membrane and postsynaptic nerve terminal. In the presynaptic nerve terminal only, it is synthesized. How it is synthesized? Acetyl-CoA is coming from mitochondria and choline is coming from the food, or it may coming from the reuptake through the choline carrier. Now these two are reacted. Okay. So this reaction is catalyzed by the enzyme. That enzyme is called choline acetyl transferase. So that enzyme is called choline acetyl transferase. So that the enzyme, this is the choline acetyl transferase enzyme. So this enzyme will combine these two, acetyl-CoA and choline, and acetylcholine will be formed. So after formation, what happens? This acetylcholine is stored temporarily in the synaptic vesicles. Okay. So when the excitation comes to the presynaptic neuron, then acetylcholine will be released. So when the action potential is coming like this, then what happens? This acetylcholine will be released through presynaptic membrane into the synaptic cleft. This action is promoted by calcium and SNARE proteins. So this is already discussed in previous chapters. Now it will act on the cholinergic receptors. So what are the cholinergic receptors? They are two types, nicotinic and muscarinic. So nicotinic receptors Why they are called nicotinic receptors? Because they will respond to low doses of nicotine also. So on the postsynaptic membrane, you may have nicotinic receptors or muscarinic receptors. Okay. So muscarinic receptors, they are named because they will respond to a mushroom poison called muscarine. Okay. So where these receptors are present, these are important. So after binding with the receptors, it will cause action. We will see that later. Then what happens? You have acetylcholine esterase enzyme on the postsynaptic membrane. It will cleave the acetylcholine in a two-step manner, and choline and acetate is removed, released, and they are separated. This acetate will diffuse away. This choline is re-entering into the presynaptic neuron with the help of choline carrier. So this is the acetylcholine synthesis mechanism. So these are the biochemical events at the cholinergic synapse. See this muscarinic and nicotinic actions of acetylcholine. You see the nicotinic receptors, where they are present? They are present at the NMJ. We have discussed the NMJ, neuromuscular junction. So there we got nicotinic type of receptors. So they are present on the postsynaptic membrane at a neuromuscular junction, that is present on the skeletal muscle fiber. What it will cause? After binding with the acetylcholine, they will cause increased sodium influx. So they are inotropic receptors. So nicotinic receptors are inotropic receptors. Means when the receptor opens, they will allow ions to pass through them. Here sodium is coming into the muscle fiber. What is the effect you can see? You can see muscle contraction. Next, in the ganglionic also you have acetylcholine. We discussed that at the ganglionic level. That is, all the preganglionic autonomic neurons will release, and postganglionic also, parasympathetic and some sympathetic neurons. So, in autonomic ganglia you have acetylcholine. Here also, it will cause increased sodium influx. This leads to neuronal excitation. Next, coming to the central nervous system. So, it is also causing here increased sodium influx, leading to neuronal excitation. So, nicotinic receptors are present at three sites: muscle, that is NMJ, and at autonomic ganglia, and in the CNS. So, in all these things, they will increase sodium influx and causes excitation of the postsynaptic neuron or skeletal muscle fiber. So, nicotinic receptors are inotropic type of receptors. Then coming to the muscarinic receptors. Muscarinic receptors are metabotropic receptors. Means they will act through G protein coupled receptors. M1. You see this M1 receptors, where they are located at the autonomic ganglia and presynaptic nerve terminals and in the CNS. They will cause increased inosine triphosphate, and the effect you can see is the modulation of the neurotransmission. So they can modulate the neurotransmission. So these M1 receptors are present in the central nervous system, autonomic ganglia and presynaptic nerve terminals. They will act through IP3 mechanism. Next, so M1 is called neuron. M2, that is cardiac. They are present on the heart, cardiac tissue. Particularly where it is present, sinoatrial and atrioventricular nodes. So at the nodal level we have M2 types of receptors. They will cause increased potassium efflux or decreased cyclic AMP. So you can see slowing of heart rate and slowing of the conduction of the electrical impulse in the heart. So there will be delay in the conduction and there will be slowing of the heart rate. Okay. So they are acting by increased potassium efflux or decreased cyclic AMP. Next, M3, glandular. So they are present on the glands and smooth muscles. They are acting through increased IP3 pathway and it leads to contraction of the smooth muscles and stimulation of the glandular secretions. Next, they are present on the vascular smooth muscle. Increased cyclic GMP as a result of nitric oxide stimulation. It leads to vasodilatation. Okay. So, we have M1, M2, M3 here. Okay. Mainly, actually, various types of muscarinic receptors are from M1 to M5. Okay. So, M4 and M5 are also present in the CNS only, but in the limited extent. So, we have discussed nicotinic receptors and muscarinic receptors. Okay. So, we have seen the acetylcholine. It is a small molecule neurotransmitter and where it is present and how it is synthesized, stored, released and how it is degraded. And we have seen the two types of cholinergic receptors. Okay, and we have seen the actions through its receptors. So we have seen the muscarinic actions and nicotinic actions. Next, coming to the biogenic amines. So this is the second classification in the biochemical type of classification. Biogenic amines includes catecholamines. That includes epinephrine, norepinephrine and dopamine. And next biogenic amine is serotonin or 5-hydroxytryptamine. We can call it as 5-HT and histamine. So these three are coming under biogenic amines. So what happens here? Now we are discussing these catecholamines. Catecholamines include these three: dopamine, norepinephrine and epinephrine. How they are synthesized? See, these are synthesized from the amino acid phenylalanine. Upon the action of phenylalanine hydroxylase, phenylalanine is converted into L-tyrosine. Then, with the action of tyrosine hydroxylase, it is converted into L-dopa. Then, L-dopa is converted into dopamine with the help of L-aromatic amino acid decarboxylase. Next, dopamine is converted into norepinephrine with the help of dopamine beta hydroxylase. Next, norepinephrine is converted into epinephrine with the help of PNMT, that is phenylethanolamine N-methyl transferase. So these are the reactions. It is the pathway of catecholamine biosynthesis. This you have to remember. Now coming to the effects of this epinephrine and norepinephrine on its receptors. So on which receptors it will act? They will act on alpha and beta receptors. So you know that alpha is again having alpha 1 and alpha 2. And beta is having actually beta 1, beta 2 and beta 3. So beta 3 is present on adipose tissue. We leave it. Alpha 1 receptor. It is present on most arteries and veins, and in the eye it is present in the iris muscle. So alpha 1 receptors, if they are stimulated, they will cause contraction of the smooth muscle. So if it is present on the arteries and veins, they will cause vasoconstriction, both epinephrine effect and norepinephrine. Vasoconstriction. And in the eye, it will cause contraction of the iris muscle. So our pupil will dilate. So it leads to pupillary dilation. Next, coming to alpha 2 receptors. They are present in the adrenergic nerve endings. It leads to decreased release of epinephrine and norepinephrine. Okay. So alpha 2 receptors, they are present on the adrenergic nerve endings. Leads to decreased release of these neurotransmitters. Next, coming to beta. Beta 1. It is present on cardiac muscle, that is the heart. So if you give epinephrine, there will be increase in the heart rate, force of contraction and conduction in the ventricular system. And in the norepinephrine, there will be moderate increase in the heart rate, force of contraction and AV conduction. So greater increase seen with epinephrine. Now coming to beta 2. It is present on the smooth muscle. It will cause relaxation of the smooth muscle. So where it is present? On the bronchial or smooth muscle, in the airway. bronchial or smooth muscle. It is causing bronchodilation. You see, this norepinephrine does not stimulate beta 2 receptors. So you can leave this. So bronchial or smooth muscle leading to bronchodilation by epinephrine. And on the uterus, it leads to relaxation of the uterus. And on the coronary and skeletal muscle blood vessels, it leads to vasodilatation. Okay. So we have effects on alpha 1, alpha 2, beta 1 and beta 2 receptors. Alpha 1 is causing contraction of the smooth muscle, whereas beta 2 is causing relaxation of the smooth muscle. Beta 2 is having only epinephrine effect. And here alpha 2, adrenergic nerve endings. Beta 1 is present in the cardiac muscle. It leads to increase in the all uh, mm, uh, all types of that is increase in the heart rate, force of contraction, conduction, etc. So there is a greater increase with the epinephrine than norepinephrine on the beta 1. So there are some differences between epinephrine and norepinephrine, though they will act on the same types of receptors. See some differences. Epinephrine, okay, is more effective in terms of cardiac stimulation, leading to greater cardiac output. Okay, we have seen that. So beta 1 receptors are present on the heart, and epinephrine will increase greater heart rate and greater conductivity and contractility on the heart. And epinephrine is also greater in effect in increasing the metabolism. So our body metabolism is greatly increased with the help of epinephrine. And this norepinephrine, this is particularly important for constriction of the blood vessels, leading to increased peripheral vascular resistance and increased arterial pressure. So our blood pressure is mostly dependent on norepinephrine. Why? Because it leads to constriction of the blood vessels. Okay. So blood vessels constriction is by alpha 1 receptors. So on alpha 1 receptors, norepinephrine is acting on a greater effect. Alpha 2 you leave it, then beta 1 epinephrine is acting more. So this is alpha 1, this is because of beta 1. And beta 2. Beta 2 is showing only epinephrine effect. So these are the differences between the actions of the epinephrine and norepinephrine. You see again here also norepinephrine and epinephrine. Norepinephrine is a hormone which serves as a neurotransmitter. Epinephrine is a hormone that increases the rate of blood circulation, breathing and carbohydrate metabolism. So in metabolism, actually epinephrine is important. Epinephrine, norepinephrine is also called noradrenaline. Epinephrine is also called adrenaline. Norepinephrine is produced in adrenal medulla and sympathetic nerves, whereas epinephrine exclusively produced in adrenal medulla. So nerves can synthesize norepinephrine. Okay. Now norepinephrine is used as a drug to raise the blood pressure. Why? Here you can see the norepinephrine. It leads to constriction of the blood vessels by acting on more on the alpha 1 receptors. So it leads to increase in the blood pressure. So you can use this in hypotension. Here epinephrine prepares muscles for exertion. Norepinephrine is a catecholamine. Epinephrine structurally similar to norepinephrine except for the methyl group. So these are catecholamines. So difference is the methyl group. Norepinephrine takes 80% of the adrenal medullary output. Epinephrine takes only 20% of the adrenal medullary output. So our adrenal medulla will produce both epinephrine and norepinephrine. 80% is the norepinephrine and 20% is the epinephrine. And this epinephrine is produced only from the adrenal medulla, whereas norepinephrine can also be produced from the sympathetic nervous system. Next, effect is mediated by sympathetic nervous system. Effect is mediated by adrenal medulla in the epinephrine. Norepinephrine binds with alpha 1, alpha 2 and beta 1 receptors. Here, epinephrine binds with alpha receptor in greater affinity. Just when you compare this. Here, norepinephrine raises the heart rate and modulates the blood pressure. Epinephrine, effective antihistamine used in treatment for shock. So, epinephrine is given in treatment for shock because it is an effective antihistamine. So, you can see these differences. Epinephrine leads to more cardiac stimulation and epinephrine leads to more metabolism, and norepinephrine leads to constriction of the blood vessels more. Okay, and norepinephrine is not acting on the beta, so it won't dilate the blood vessel. When you compare these things, norepinephrine can bind to alpha 1, alpha 2 and beta 2, beta 1 receptors. Here, epinephrine binds with the alpha receptors in greater affinity. Next, coming to vasomotor reversal of Dale and vasomotor re-reversal of Dale. So, what is this vasomotor reversal of Dale? So, if you give adrenaline, we are seeing BP. So, we are measuring blood pressure of an individual and we are injecting adrenaline into the bloodstream. Then what happens? There will be action on the alpha 1 receptors initially. So, there will be increase in the BP because of the constriction of the blood vessels. Then then what happens as time goes on, the adrenaline concentration in the blood will be decreased. So at low level of adrenal concentration, it will act on the beta 2 receptors. It leads to decrease in the BP. This is a biphasic reaction because of the adrenaline on the blood pressure. So initially if the BP is 120 mmHg, because of alpha 1 action, because adrenaline at high concentrations, it will act on alpha 1 receptors, leads to constriction of the blood vessels and leads to increase in the BP up to 160, for example. Then after some time, the adrenaline is excreted from the body and its concentration level decreased in the body. At the low concentration, it will act on beta 2 receptors and it leads to decrease in the BP to 200, for example. This is a biphasic response of adrenaline on blood pressure. So this is a normal thing. But what is vasomotor reversal? Now we are giving adrenaline intravenously and we are also giving alpha non-selective alpha blocker. So it will block the alpha receptors. So what happens? There is no rise in the BP. Only you can see fall in the BP. This is called vasomotor reversal of Dale. Then what is re-reversal of Dale? Now we are injecting adrenaline IV and we are giving beta blocker, non-selective beta blocker. Then what you can see? Only rise in the BP you can see. There is no fall in the BP. So they are monophasic reactions. So vasomotor reversal and re-reversal, they are monophasic reactions of adrenaline on blood pressure. Now coming to the removal and metabolism. So how they are removed? This epinephrine with the help of COMT, that is catecholamine O-methyl transferase, it will be converted into metanephrine, and norepinephrine also converted into normetanephrine. And they can be converted into dihydromandelic acid with the help of monoamine oxidase. And all these things, and this dihydromandelic acid can also be converted into vanillyl mandelic acid with the help of COMT. And this metanephrine, normetanephrine can be converted into VMA by monoamine oxidase. And this VMA will be excreted through urine. So all these are converted into VMA and excreted. This flow chart is important. Next, coming to the dopamine. So there is another biogenic amine, that is catecholamine only. So we are discussing it separately. Dopamine. So dopamine acts on these receptors, D1 to D5 receptors. Where they are present, we have seen the biosynthesis already. Then what are the receptors? D1 receptors present in all these locations. So olfactory bulb, nucleus accumbens, striatum, amygdala, hippocampus, frontal cortex, substantia nigra, hypothalamus. All these will contain D1 receptors. They are G stimulatory. So all these are metabotropic receptors. They are GS coupled receptors. What is the mechanism? There will be increased cyclic AMP. What is the function? It will lead to attention, learning, locomotion, sleep, impulse control, regulation of renal function and memory. Next, coming to D2 receptors present in the olfactory bulb, striatum and cortex, GI coupled, inhibitory. Okay. Increased levels of cyclic AMP leads to reproductive behavior, locomotion, sleep and attention. Now D3 present in the cortex, striatum, GI coupled. This is for the locomotion, regulation of food intake, cognition. D4 present in the hypothalamus, amygdala, frontal cortex, needed for attention, impulse control, reproductive behavior. And D5 present in the hypothalamus, substantia nigra and cortex, GS coupled. So they will increase cyclic AMP. They will be important for motor learning, cognition, decision making and renin secretion. So these are the receptors for dopamine. Now how the dopamine is excreted. So dopamine, you see, with the help of monoamine oxidase, so it will be acted by MAVA enzyme, okay, or a COMT. So if it acted by MAVA enzyme, it will be converted into DOPAC. It is 3,4 dihydroxyphenyl acetic acid. If it is acted by COMT enzyme, it will be converted into 3-methoxytyramine. Then with the help of COMT here, MAVO here. So exactly opposite. It will be converted into homo-vanillic acid and it is excreted. Next, coming to the next biogenic amine, that is serotonin. Serotonin is formed from the tryptophan. With the help of tryptophan hydroxylase, will be converted into 5-hydroxytryptophan. Okay. Next, how it is degraded? This 5-hydroxytryptophan or this 5-hydroxytryptophan is converted into 5-hydroxytryptamine by decarboxylase enzyme. Now this serotonin or 5-hydroxytryptamine is converted into 5-hydroxy-indoacetic acid and excreted in the urine with the help of MAVO enzyme. What are the functions of serotonin? It will act on all these receptors. So 5-HT1 to HT7 receptors. So 5-HT1 is having again subtypes A, B, D, E, F. They are G protein coupled receptors. So all these receptors except 5-HT3, they are G protein coupled receptors. So metabotropic receptors. Only 5-HT3 is ligand gated ion channel. So 5-HT1, they will function as inhibitory auto and hetero receptors. So it is relevance. It is so they are called triptans. They are used in acute migraine medication. So we are giving 5-HT 1B 1D agonists. They are called triptans. So and F also. They are proven to be effective in the treatment of migraine. And HT2, they are G protein coupled receptors. They are excitatory. Okay. And HT3, they are ligand gated ion channels. They are also excitatory, involved in descending pain facilitation. And all these are G protein coupled. Okay, excitatory or inhibitory. No known implications present. So in detail, he is giving 5-HT3 where they are present. Okay. So they are present in the area postrema, endorenal cortex, frontal cortex and hippocampus. They are non-selectively acting. So sodium or potassium can enter or exit through this. Now coming to the histamine. Okay. So this is the last biogenic amine. Histamine is formed from histidine with the help of histidine decarboxylase. Now this histamine can be degraded to N-methylhistamine or imidazole acetaldehyde and excreted with the help of these enzymes, diamine oxidase or a HMT. So the different histamine receptors are H1, 2, 3 and 4. So these are G protein coupled receptors. So where they are present, H1 present in the heart, brain and mast cells. They will modulate the functions of smooth muscles and leads to vasodilatation. H2 receptors present in the heart, brain, parietal cells, neutrophils. On stimulation, it leads to release of gastric acid and modulation of leukocyte function. And H3 receptors present in the brain and peripheral nervous system. They can modulate the nervous system activity. H4 present in the blood cells, that is on the mast cells, eosinophils, monocytes. They will modulate the allergic reaction. This slide is very much dull. H1. So H1 receptors antagonists can be used in allergies, nausea and sleep disorders. H2 receptor antagonists they will use in the stomach ulcers. Okay. And H4 also the receptor antagonists can be used in the allergic conditions. Now coming to the amino acid neurotransmitters. First one is the glutamic acid or glutamate. Glutamic acid or glutamate is formed from glutamine with the help of glutamine synthetase. Now this can be converted into alpha ketoglutarate or alpha ketoglutarate the glutamate can be formed. This alpha ketoglutarate can be coming from citric acid cycle. This glutamate is converted into GABA with the help of glutamate decarboxylase. GABA is also an amino acid neurotransmitter. This is the glutamate excreted through urine. Now the receptors are quite interesting. It can be act on the inotropic glutamate receptors, metabotropic glutamate receptors. Coming to the inotropic glutamate receptors, they are AMPA or kinase receptors. So they will cause sodium to come in, potassium to go out, and NMDA receptors. Sodium to come in, potassium to go out, and they need magnesium, zinc, okay, calcium, all these things. And metabotropic glutamate receptors, they will act on the G proteins. See, metabotropic glutamate receptors. This is the diagram. This is the receptor. This is the G protein. So we have different groups here 1, 2, 3. So 1 includes 1 and 5. It will act through phospholipase C mechanism. Group 2 it will act through inhibition of adenine cyclase, and group 3 is also acting on inhibition of adenine cyclase. So group 1 it will act through GQ mechanism. Group 2, 3 they will act through GI mechanism. Now see at the synapse level what happens. The released glutamate can act on kinase receptors, okay, or AMPA receptors or NMDA receptors. And this remaining glutamate will be absorbed through glial cell and it is converted into glutamine by glutamine synthase, and this glutamine enters into the presynaptic nerve terminal with the help of glutaminase with the help of some transporter, and glutaminase enzyme is present in the presynaptic nerve terminal and it will turn the glutamine into glutamate. Next coming to the aspartic acid or aspartate. Next amino acid neurotransmitter. So this is the formation of the aspartate through oxaloacetate from the Krebs cycle. So it is also an excitatory neurotransmitter, that is glutamate and aspartate both are excitatory neurotransmitters. Next coming to the GABA. It is an inhibitory neurotransmitter. How GABA is produced? From glutamate by decarboxylating enzyme. So this will act on GABA A, B and C receptors. So A and C receptors will open the chloride channels. Okay. And GABA B receptors They will open the potassium channels or they will close the calcium channels. This GABA B is widely distributed throughout the brain. Okay. So GABA A, GABA B, GABA A are inotropic receptors, GABA B are metabotropic receptors. See this GABA A ligand gated ion channel. This A and C are inotropic receptors. B are metabotropic receptors. GABA A where they are present? Widespread they are present mainly at the postsynaptic. And GABA B they are present in the pre and postsynaptically. Structure GABA A they are pentamers. GABA B are dimers. Mode of action GABA A will increase postsynaptic inhibition by increased chloride influx. So the neurotransmitter GABA is released from the presynaptic nerve and it will act on the postsynaptic nerve terminal and it will leads to increase in the chloride influx. So there will be no excitation. And GABA B it is presenting presynaptically it will cause decreased calcium entry and postsynaptically it will cause increased potassium permeability. Okay, so endogenous agonist GABA. This is a GABA shunt. That is from the Krebs cycle you have alpha ketoglutarate. From this you have glutamate and GABA is formed from the glutamate. Then this GABA is converted into succinic semialdehyde and this will converted into succinate and re-enters the Krebs cycle. So this is called GABA shunt. Now just you can see what are the differences between glutamate and GABA. So these are the major neurotransmitters in the brain. So glutamate is excitatory and GABA is inhibitory. So physiological function on the molecular level if you see, glutamate is a major excitatory neurotransmitter and neurocyte energy metabolism. So it leads to alternate energy source. So it is important in the neurocyte energy metabolism and it also acts as a regulator in the neurogenesis and it also is a modulator at the synaptic transmission. And coming to the physiological brain functions, it will control the movement in basal ganglia circuitry and it maintains cognitive functions. It is important for sleep control and pain signaling. And GABA is a major inhibitory neurotransmitter and it modulates the excitatory neurotransmission and it is important for timing and synchronization of the neuronal signals and it is also helpful for the neurogenesis regulator. So like glutamate, GABA is also important one for the regulation of the neurogenesis and it is essential for the prevention of excitotoxicity and it is also helpful for sleep control, mood and anxiety control, neurodevelopment, regulation of neuroendocrine system and it also functions outside the central nervous system like control of GIT motility, modulation of airway tonus and regulation of insulin, somatostatin and glucagon secretion. So GABA is acting outside the CNS also. Dysregulation of GABAergic or glutaminergic system, if you see, there will be neurodegenerative diseases. So if a glutamate is a system fails, then there will be occurring of neurodegenerative diseases like Alzheimer's, Huntington's, amyotrophic lateral sclerosis, Parkinson's disease. If GABA is failed, then you can see sleep disorders, that is insomnia, hypersomnia, and neurodevelopmental diseases like autism. Next, coming to the glycine. This is also amino acid neurotransmitter. So glycine is an amino acid normally which is present in the proteins. It is also inhibitory neurotransmitters, particularly in the brainstem and spinal cord. Glycine acts on NMDA receptors, okay, such as glutamate and glycine must be present for activation to occur. So it is acting as a co-agonist actually, co-agonist. So here glycine is attached to our NMDA type of receptors. Here glutamate is attached. So it is co-released. So glutamate is released, glycine is also released from the presynaptic nerve terminal. So it is essential for the activation to occur by glutamate. So if you see glycine, this has the inhibitory as well as excitatory effects. Okay. Inhibitory neurotransmitter. It is acting as an inhibitory neurotransmitter, particularly in the gray matter of the spinal cord and brainstem. So it causes direct inhibition, that is postsynaptic inhibition. How it acts? It increases the chloride conductance in the postsynaptic neuron. And glycine, when binds to NMDA receptors, what happens? It makes them more sensitive to glutamate action. So therefore, it facilitates the mainly pain transmission by NMDA receptors. So both it is an excitatory and inhibitory neurotransmitter. And pituitary hormones like ACTH, adrenocorticotropic hormone, alpha MSH, alpha melanocyte stimulating hormone, beta endorphins, growth hormone, prolactin, follicle stimulating hormone, luteinizing hormone, thyrotropin. Okay, all these are pituitary hormones. And GI and brain peptides like cholecystokinin, gastrin releasing peptide, motilin, neurotensin, substance K and substance P. And circulating hormones like angiotensin and bradykinin. And opiates. They are beta endorphins, dynorphin, leuenkephalin, and metenkephalin. So opioid. So and neurohypophyseal peptides like oxytocin and vasopressin means they are releasing from the posterior pituitary. And neuronal and endocrinal, that is ANF, atrial natriuretic peptide, calcitonin gene related peptide, and vasoactive intestinal peptide, and glucagon pancreatic polypeptide, and all these things neuropeptide Y, peptide YY, calcitonin, insulin, secretin, parathyroid hormone, all these are large molecule neurotransmitters. So each one will not be discussed here. So they will be discussed in the related topics like pituitary hypothalamic hormones. They will be discussed in the uh, endocrinal chapters. And regarding GIT, we will discuss about GI hormones. So some important points only we will see here. So all these many of the peptides function in communicating the network. They are present within the neural system, endocrine system, and immune systems also. They will alter the ion channel function and modify cell metabolism or the gene expression. And these actions can be sustained for minutes, hours, days, or even longer also. Okay. So these neuropeptide transmitters are actually slowly acting and have a prolonged effect. Okay. Whereas small molecular rapidly acting and have a short lasting acute response. These are synthesized in the soma and they are carried through they are carried through our microtubules with the help of uh, the proteins, and they are packaged into vesicles in the Golgi apparatus. So first they are synthesized in the cell body, then in the Golgi apparatus they are packaged into vesicles and they are transmitted to the nerve terminal. So these are not synthesized at the axon terminal. And see these neuroactive peptides, they are released from hypothalamus. And pituitary peptides, you can see anterior pituitary can release and posterior pituitary can also release pituitary peptides. And particularly peptides acting on the gut and brain, the important things are opioid peptides. So they are enkephalins. So enkephalins, these are the peptides that binds to opioid receptors and are called opioid peptides. So in this actually the important thing is opioid peptides. So it can come as a short note, opioids. So opioids are Enkephalins, they will bind on the opioid receptors and they are called opioid peptides. Enkephalins are two closely related pentapeptides. So enkephalins consisting of met-enkephalin and leu-enkephalin. And mostly they are found in nerve endings of the GIT and many parts of the brain and substantia gelatinosa of the spinal cord. So these endogenous opioid peptides are synthesized as a large molecule precursors. Then they are broken down. So these act on three types of receptors. Okay. So what are these three types of receptors? Opioid receptors, mu, K, and delta receptors. So they differ in their physiological effects by acting on these various opioid receptors. Okay. So these opioid receptors are G protein coupled receptors. They will act by inhibiting the adenyl cyclase. So they are G inhibitory. Mu receptors, they will increase the potassium conductance. And whereas this kappa and delta receptors, they will close the calcium channels. So with all these effects, what they will cause? They will cause hyperpolarization of the neurons. So the neuron won't be excited. Okay. So this is regarding opioid peptides and opioid receptors. So next coming to substance P. It is a 11 amino acid structured protein. It belongs to tachykinin family. It is released from primary pain nerve endings in the spinal cord and hypothalamus and nigrostriatal system of the basal ganglia. Okay. So this acts on three types of receptors, NK1, 2, 3. This substance P preferably binds to NK1 receptors. So if it is binds, it causing activation of the IP3 and DAG. That is, it will act to GQ type of GPCR receptors. What it will cause? The substance P. So here two things are important. Opioid and substance P. These two are important. The actions of substance P are, it is a mediator of the pain transmission in the dorsal horn. And in the hypothalamus, it plays a role in neuroendocrine regulation. And in the skin, it is a mediator released by nerve endings and it is responsible for axon reflex. And intestine, it is involved in peristalsis. And antagonists for NK1 receptors, they are used as a treatment for antidepressants and antiemetics for patients who are undergoing chemotherapy. Okay. And regarding all these remaining things, we will see later in the concerned chapters. See this, here it is synthesized in the soma and is packaged into vesicles and it is transmuted and it is stored in the large dense core vesicle. So a large molecule called POMC or pro-opium melanocortin is degraded serially and in the anterior pituitary it is releasing ACTH and beta lipotropin. Okay. And in the arcuate neurons of the pituitary it is in the arcuate neurons in the it is present in the hypothalamus. It is converted into beta endorphins. Okay. And intermediate pituitary produces alpha MSH and beta endorphins. Okay. So we are seeing the formation of ACTH and beta lipotropins and beta endorphins and alpha MSH. So this is the important one. This will be discussed in detail in the endocrine chapter. So just POMC is the polypeptide which has no opioid activity. Now it is degraded. This is the POMC. It is degraded into ACTH, okay, and beta lipotropin in the anterior pituitary corticotropes. and in the arcuate neurons it is degraded to beta endorphin. Okay. And then in the intermediate pituitary arcuate neurons, intermediate pituitary, so it is not actually present in the human beings. In the intermediate thing, it will be converted into alpha MSH. This alpha MSH leading to skin darkening. Then next video is about somatosensory system.